So we have a few participants who have joined in. I was thinking to maybe um just wait for another minute or so before starting. Till then, maybe we can have a little discussion with the participants who have joined in. So if you can just write down in the comment box that when are you guys planning to give your exam? Are you a beginner, like who has just started the preparation? And if any one of you have any questions regarding any of the stations, you guys can ask or write in the chat box too. Yeah, I'll just wait for another minute for a few people to join in, and then we can start with the topic. Yes, Dr. Asma, you just started the preparation. Best of luck. Let us know if you need any further guidance. If you want any guidance regarding the preparation, regarding how the exam works, we are here to tell you about that. Dr. Sara, you have exam in February 2026 and you have started preparations recently. So I think it's a good enough time. You have 3 months, and usually we say that if you have some already have some experience in the pediatrics, so 3 months is a good time to prepare. Okay, you have submitted your application today, Dr. Sara. That's really nice. Best of luck for getting the seat. Let us know if you have any trouble coming up or if you feel that there's anything that you need special guidance with. Okay, so we have some of our the course candidates as well. Dr. Batuhan is here. Then we have some other participants. So welcome, Dr. Asma, Dr. We have two Dr. Asmas, Dr. Lubna, Dr. Sharan, Faika, Dr. Jaya, Dr. Tahira, Uzma, Zaid, all of you. If you have any of your friends who are preparing for the exam, you can message them to join in as well. So Dr. Lubna is saying that she's also started the clinical prep recently and you have already done FCPS pediatrics. So that's really nice. If you have already done FCPS, so you will have a good basics. But this obviously you know that this exam is a bit different from the FCPS. So yes, you will have to unlearn certain things and then learn a few other things as well. Dr. Asma, Walaikum Assalam, and you have started your preparation as well and you're planning for 2026. That's a good aim. Yeah, Dr. Batuhan, I really hope that you get the seat because we're really hopeful that you get the seat and you make us proud as well. So let's begin with today's webinar. Yes, I'm sorry I got disconnected. Let me just recheck my internet connection and then we can start. Okay, just let me know if my voice is clear and my screen is visible so that I can start. Okay, so a lot of people here have applied. Dr. Shweti. Okay, so we'll start with the guidelines. Am I audible? If anyone can message, Dr. Sarish, can you hear me? Okay, thank you. Okay, so for those who have not joined before and who are new, let me introduce myself. I am Dr. Iqra Ahmad. I am currently working in Pakistan. I did my MRCPCH from Pakistan in September 2023. So it's been more than 2 years that, and since after passing, I have been associated with the teaching. So it's been almost around 2 years of teaching the candidates. I've also done FCPS pediatrics, and currently I am doing my fellowship in the pediatric neurology. So today our aim was to discuss some guidelines and do so practice of communication and give the chance to the people who are preparing and who might not be in the course and they need a chance to prepare with us. Um, Eczema guidelines, that they have been recently introduced into the new guidelines. Previously, in the 2022 to 24 guidelines, there were no eczema guidelines. However, the topic is really important, so we used to read it from the other sources, like from the leaflets, from the websites as well. But with this, from the 2025 to 2028, they have specifically added two different topics of the eczema. So I wanted to discuss through this, and then we'll discuss two communication. So any one of you, today I want to give the chance to the people who have not done anything with us before. So whoever wants to volunteer for the communication stations at the end, please do message so that I can select that you guys can practice. So tell me, who will tell me what is eczema? I want the session to be a little more interactive one rather than just me teaching it. So let's just keep it something in which you can give your input and we can have a mutual discussion. So can anyone define or just tell, we don't really need the definition, we just want to have an idea. So those who have recently passed AKP, so which was the scenario in the questions that used to come as eczema? Yes, you can message me as well. Getting a few messages. I want someone to maybe unmute themselves and see. It's fine. It's not really an exam. I'm not going to mark you down for this. So whoever has done the AKP recently, yeah, the savior of everyone, Dr. Sarish, you have unmute yourself.
I
Yeah,
was waiting for somebody else to.
it's fine. I think you
It
can
will be it will be a child infant in which we can see dry, itchy, scaly skin. There could be redness, erythema, and it could be a simple flare up. It could be complicated as well. Mostly located.
Sorry, are you saying anything, Dr. Sarish?
Can you hear me?
No, I think you got mute and then I was your voice.
Okay, so I was saying that eczema is so it basically involves dry, itchy, red skin. It could be simple eczema. It could it can come and go in flares. So mostly located on the flexure surfaces of infants.
Yeah. So it's basically skin condition. It could present just as a skin condition, or it could be associated with other atopic conditions, and it could be associated with the food allergies as well. So what I was asking from the AKP candidates was that there's always used to be a question of a child with a rash on the face, and they used to ask that what diet changes that you have to do, and then in which the cow milk protein allergy was there as well. So yeah. So according to NHS, eczema is a common long-term skin condition that causes the skin to become dry, red, and itchy. It is often called as atopic eczema or atopic dermatitis and can appear as patches that may be red, crusty, cracked, or thickened. Right? So the thing is that this is obviously you're not going to get a patient who has this skin condition because obviously they are not there for the clinical examination. So eczema is not the topic for your clinical stations. Then why is eczema important? Because eczema can come in the history station. Very commonly, eczema herpeticum, it comes with if you look at the recalls, you'll find that there are multiple history stations, history recalls in which there's a child with eczema. It could be infected, it could be due to any allergies, it could be due to the eczema herpeticum. For the communication, again, it's a very important topic. It can come in multiple forms. We're going to practice those as well. And then it can come in the video stations as well, right? So you see three stations, and you can get this topic in any of these. So that's why it's really important to know that what is the management of this, right? So the good thing is that you have gone like got a proper guidelines in which you're going to learn them, and then you're going to reciprocate them in your exam. So the guidelines starts that okay, so you can have two kinds of scenarios. So obviously, a child who has simple skin infection, who does not have any serious condition or any criteria for admission, obviously that patient is going to be managed by the OPD, like on the outpatient basis, right? And obviously, we're going to go through a scheme that how do you manage that patient on the OPD basis and what should be your treatment protocol. And that is going to help you when you are going to um, do the communication of a child, in which you have to tell the treatment to the parent, to the father, or even the child, him or herself, that what is the treatment for that, right? But if there's a patient who is admitted, like you can get in the history if you're getting a station in which the um, eczema is complicated, it's not getting better, or it has gone worsened with the secondary infection, then obviously you're going to go for the admission. So why it is important to know that which case needs admission is that when you are telling it in the history, you need to know according to the history that whether this child needs to be admitted or not, and then you have to mention it in your management plan. So the possible reasons for the admission in the cases of eczema is that the child is not improving despite adequate therapy at home. We are going to discuss that what are the steps of therapy. Severe erythrodermic eczema, in which means that skin is really red, it's like maybe um itchy, and then due to itching there's some bleeding, so it's a quite a bad reaction going on. Generalized weeping, hemorrhage, exudates or crusts, right? So if it's getting like crusty and there's a blood coming out of it, or the cases of eczema hepaticum. So eczema hepaticum, again, it's if you remember from the AKP, so there used to be a very typical picture of like an eczema, a child who had eczema, and then this reddish all over, and the child is getting suddenly sick. So eczema hepaticum is an absolute indication for the admission. So what do you do when a child has been admitted? So this for in the first one, this is all it when you are managing in the hospital. But some of its points go to the OPD basis as well, right? And by the end of the presentation, I'm going to share like a journal chart in which how can you manage a child overall. So the guidelines say that in the nursing intervention and the management, you have to assist the child and parent in ensuring prescribed creams applied every hour. So the thing is that the main thing in the eczema is that the skin is really, really dry. It's flaky, it's dry, and due to that dryness, it becomes itchy. So the first step in the management of eczema, whether it is OPD, whether it is admitted case, is to apply the emollients and apply the creams properly, right? So you have to like ensure that the parent is doing that. Ensure that the child baths twice a day, because if the child because you're applying a lot of things on the body, so you don't need to like keep on reapplying on the same skin. So obviously you need to give proper bath, and after bath within minutes you have to reapply those things, right? These are the general things that you have to see. So this can come up as a discussion with the parent, or this can come up as a discussion with the examiner as well. Always use spatula to remove cream and ointments from the tubs. Do not use hands. So can anyone tell me that what is the rationale behind this specific point?
Bacteria when you use your hands. So that's and the skin is very sensitive, baby skin.
Yeah.
So
So this is
that's why.
one of the very faulty thing. This is something that you need to tell it in your practice to every parent. Like even if the child is not eczematous and the child is only having a some kind of rash, or even if the parents are applying any of the diaper rash cream, which is like they have to take it out of a tub. So always tell them that do not use the same finger that they're applying it with on the skin, because that's going to carry the organisms, or that's going to carry any of the germs into the tub or ointment, right? Then observe the skin for signs of improvement or deterioration on a daily basis. Assess and monitor nutritional intake. That's really important as well, because if the child is admitted and the child might be sick due to fever or anything, you have to take care of that. Inform the doctor of any concerns, changes in the condition, liaise with the dermatology nurses and arrange follow-up appointment, encourage compliance. So this is basically the nursing thing that we are going through, but you have to tell it that you have to take these things, because you see, when you are managing a patient in all of I feel that a lot of you who are here have done FCPS pediatrics or any other pediatric examination. And in that, your aim is to tell like the things which are like high and high up. Like you have to get to the end of the possible treatment. However, in the cases of MRCPCH exam, it's not the case. It's that you have to tell the basics. You have to ensure that the parent, the caretaker, is well aware of the condition, knows all the things what have to be done, and they are in good like understanding of the disease, rather than telling them 10, because telling the high treatments, that is the purpose, or that is the job of a consultant, right? But you, as a, like you're giving this exam, you are going it at like for the ST3 ST4 level, you are giving a middle tier exam. That's not like a consultant exam. So you have to know that you have to mention all of these things. If you have seen this child, like maybe if you get a video, you'll have to tell all of these things to the examiner. So encourage compliance at home, explain importance of this to the parents and child, ensure good supply of the prescribed ointments, creams. So this is basically what you have to do, the side care. So how do you manage basically? Okay, so if you have a child of infected asthma, right? Eczema, sorry. So infected eczema. So what are the common organisms that can cause infection on the top of eczema? What are the that organism that causes the skin infections? Is it gram positive,
Staph
gram?
aureus.
Yes, Staph aureus. That's right. Yeah. So basically, the organisms which are basically involved are the Staph aureus, beta hemolytic streptococcus, and in the virals, you have to, they are basically the herpes, the eczema hepaticum. Yeah, herpes, staph, eczema, all of these things. Yeah. So it could be bacterial infections, it could be viral infections as well. Thank you, Dr. Mustafa, Dr. PK. So if you have a child with infected asthma who has been infected, you have to nurse that child inside a room or a cubicle. Like you have to like keep that child separate. You have to reserve bathroom for the patient and place a sign on the door. Obtain viral and bacterial swabs from the affected area and send for the testing. So I usually you don't do any testing in the cases of eczema, right? That's a skin condition that you have to like clinically diagnose and you have to manage it clinically. Signs of infection, or the child has any sick condition, fever or anything like that, then you have to get the viral and the bacterial swabs from the affected areas. Like if there are any crusting, if there is any weeping going on, you can take that and send that for the testing. And then monitor and document observations 4 hourly on the pediatric early warning score system. So this is basically a scoring system in which you basically monitor the vitals, you monitor the overall clinical condition of the child, and you assess that whether the child, because you see, if when the child gets this staph or the strep infection, the child is at the risk of getting into the sepsis or getting the deteriorated as well, right? So you need to keep an eye that whether the child is getting deteriorated. Now we come to the treatment of any eczema, right? So remember, whenever you're telling, you can get a scenario in which you have to tell the treatment of the eczema to the parents. So it's never like, even if the condition is worsened, even if it's infected, you wouldn't go to the high level thing. You always have to start from the basics and how would you manage that. Obviously the treatment would be different in the cases of mild, moderate and severe, depending upon the dosages and everything, but you always start telling the treatment from the beginning. So what is the first step of treatment in the cases of eczema? What's the first step? Anyone of you has managed eczema? So what's the first thing that you advise to the parents and you prescribe?
Good hydration and moisturizing of the skin.
Yes, moisturizer, avoid triggers, emollients. So can anyone tell me that what is the difference between the moisturizer and emollient? Yeah, Dr. Shawal Sajid, you mentioned emollient. So can you tell me what is the difference between a moisturizer and an emollient? Anyone else?
Moisturizer keeps the area hydrated.
So what is emollient?
Hi, Dr. Iqra. Emollient is a
Yeah.
water-based moisturizer. The base is and moisturizer, I think that is fat-based, the ingredient. Both are moisturizers. Water-based moisturizer is emollient.
I think the difference is moisturizer is like we use general skincare. We use a moisturizer. Emollient is where the
Moisturizer has, it's a
medical grade
fat-based.
moisture. Yes, so it is
Um,
something which is medically prescribed.
yeah, oil-based. The emollients are water-based.
Oh, sorry. I think my mic got off. I'm so sorry. Am I audible now? My mic got off.
Yes, now
Yeah.
Dr. Ikra.
Okay. Yeah. So I think maybe you guys. So we were discussing that. Yeah. So emollients, we discussed that they are the typical. They are the thick, most. They're the thick, specific products that basically put found the fill the gaps between the skin layers, between the cells of the skin, and they form a barrier. So they give moisturization, but they give you a protective layer on the skin as well that prevents that moisture to get out of the skin, right? So it's like has a double role. So along with the emollients and all of those things that we prescribe to the patient and you start giving that, before that you have to give an extra advice to the parents, is that you know that when the child itches, so a lot of injury comes in the eczema because of the repetitive itching, because that is really dry and itchy, and because of that itching it could be red, it could like bleed as well. So you have to counsel the parents regarding the nail care as well, right? It is mentioned in a few guidelines, but it's not usually mentioned in every time. But when you are telling to the parent, so along with the treatments that you are prescribing, you have to tell about taking good care of the nails, keeping them short and clean. And at times what we also advise is that if the child is itching a lot and is not getting control, then have the child wear the mittens, or the gloves, so that it's not like the nails are not really penetrating into the skin and causing a lot of injury, right? So that's an added point that you have to counsel about when you are discussing the eczema. So moving forward, yes, emollients. So basically, you have to use the emollients your first therapy. So you can, there are different like types. Like you can use this bark oils that you can use. So you will like ideally it is recommended that bath the child twice daily. Use child's usual oil or oilatum. If infected, use dermol. So oilatum is basically oil-based formula that could be used during the bath or like apply it on the skin. And dermol 600, it's a specific formula. It has oil as well, and it has certain disinfectant like anti infected property as well. So it basically has two active ingredients, emollients, which is liquid paraffin, or it could be like other component like isopropyl, different agents. And then it has certain antimicrobials, which could be in the form of chlorhexidine or like other benzalkonium chloride, which basically help to combat the bacteria. So if the child is having infected eczema, you will use the Dermol 600. Otherwise, you can use the oilatum. Soap substitute. So usually we do not advise them to use the regular soaps. Ask them to use the emulsifying ointments for baths in addition to the bath oil and for washing hands. Why? Because the regular soaps, they are like really dry because they have certain pH and they makes the skin dry and they get the moisture out. So you avoid using the regular soaps. Again, if infected, you use the Dermol 500 lotion. Then moisturizers. So there are different, like these are different names that are used here. So moisturizers have different categories as well. They could be like less. If you even if you see the regular moisturizers in your practice, like if there's a Neutrogena or if there's a CeraVe, they have this different thickness levels of how much content do they have and how much moisturization do they provide. So there's 1, 2, 3, 4, 5 levels there as well, right? So obviously, if there's a drier skin, in the cases of eczema, you will get the moisturizer which has like more hydration and is more of a thickened formula. So if the child has been seen in dermatology clinic, apply usual emollients 2 hourly, or if not seen in the clinic, so Cetraban is basically like just a regular moisturizer cream. That's like a brand name. Ointments, for example, emulsifying ointment, hydromol, epiderm, xeroderm, all of these are again the different terms used for the different emollients. If infected, if infection is present, then you do not use this. And then there's indication that leave more than 20 minutes between the application of the moisturizers and then applying any topical steroids. So obviously, if the child is like has a severe condition and you have to apply the moisturizers as well, and then you apply the steroids as well. So do not do that at one time. Obviously, apply one thing, let it absorb into the skin, and then apply the second thing. So first thing is your good moisturization and locking in that moisture into the skin. Then second thing comes as topical steroids. So if like it's like, so there are different categories: mild, moderate, and severe of the eczema. So if the child is not responding to the emollients, then you will use the topical steroids. There are different steroids that could be used depending upon the potency. I'm going to discuss in the next slide as well. So what's written here is that the first point is that do not use the topical steroids in the cases of the eczema herpeticum until no new lesions appear for more than 48 hours. So usually if it's an uninfected and like simple moderate to severe eczema, you will go to the steroids, but steroids are contraindicated in the cases of eczema herpeticum. Again, this is one of the questions which the examiners ask as well, right? So this is an important point to remember. Regarding the topical steroids, you usually apply them twice daily to eczematous areas. Apply for like this amount of hours. I think it's written like that. I'm not sure. It's like I just wrote exactly 100. Is it exactly 100 hours or yeah, it's like this. 1000 hour or 1800 hour. Use topical steroid ointments rather than creams. So you see there's certain difference between the ointments and the creams depending upon their availability of the steroids and the rate of their absorption. So what's recommended is the steroid ointments rather than the creams. So strength of the topical steroids for face and body depends on the age of the child and the severity of eczema. So you need to be very careful in prescribing and knowing about the steroids. So obviously you do not need to have a lot of like information that you have to know that each strength and all of these, but you need to know a rough idea that which one is a like a lower one, like hydrocortisone. It's like the low potency steroid. So you usually start with that, and gradually you go towards like the betnovate, which is the higher potency steroids, right? For face, always go for the lower potencies because the skin is already thin and you do not want to cause any of the side effects. So journal recommendations which are mentioned here are that in the age less than 2 years, you use the hydrocortisone 1% ointment. Older children not responding to the to hydrocortisone. So if they are like, ideally you always start with the low dose hydrocortisone, but if the child is more than 2 years and the child is not responding to the hydrocortisone, you can step up to the clobetasone. This is like the humor weight is the name. And if the child is not there, then and the child has very severe eczema which is not responding to this mild to moderate, then you can go to the high levels like the potent steroids. For example, the beta methasone, betnovate may be needed. So you see, a lot of people do is that they start with the betnovate. Like in the local practices, obviously in the NHS is not there, but in your usual practice, you might find people who are using betnovate for the face as well, and they're using it as a first treatment as well. So that's not really recommended. Along with that, obviously, because there's an element of itching and that is causing the trouble to the child, so you will recommend some antihistamines. So sedating histamines more than 1 year of age, use appropriate dose for age and weight. You can use promethazine or elimemazine is one of their the which has a less sedating effect as well, right? In the cases of infected asthma, like if you have a case of infected asthma which is admitted in your ward, in all the cases, we have already discussed that we have to take more than two skin swabs for the bacterial culture. You have to take the swabs for the viral culture, like, and you have to like give properly transport them in the viral transport medium for the herpes simplex infection. And as we have already discussed, staph and the streptococcus are the main organisms. So, what is the management of the infected? So obviously, when it is infected, it means that it is like being invaded by an organism which is like bacterial or the viral. So you have to treat that specific organism along with the general care of the eczema as well. So the treatment recommendations is flucloxacillin oral for 10 days. If the child is taking oral, if there's a good oral intake, so you'll start with the flucloxacillin. You'll see in the guidelines, if you have already started going through the guidelines, so everywhere when there's a penicillin mentioned, it's always mentioned along with that if the child, there's always a second option that if the child has penicillin allergy, you will go for another medicine. So in this case, it's written that if the child has penicillin allergy, you will use the erythromycin. High incidence of staphylococcus resistance in the atopic eczema. So you can get cases which are like, the methicillin resistant Staphylococcus aureus. And obviously, if MRSA is present, then you need to go for the higher agents. And if the child is vomiting and is unable to tolerate oral, then obviously you will go for the IV antibiotics, depending upon the cultures or depending upon whatever the local protocols are, right? If the child has attended the dermatology clinic, use prescribed steroid creams and ointments. So you see, there are different clinics that are there. So if the child already is on the treatment of there, you can use the similar steroid creams or the ointments. Then comes the eczema hepaticum, very important topic regarding your history. Yeah, so very important topic regarding the history is eczema hepaticum. So how does it present? Has anyone of you ever done the practice of this eczema hepaticum? What's the usual presentation?
Severe itching.
Okay, itching is there, yes. Yes, Dr. Essay, you have written, yeah, yep. So can you tell me that uh, what's different? Itching is present in all the cases of eczema. So what's different that comes in the herpes, eczema hepaticum? So basically, yeah, I've got some responses. Bad eczema, vesicles, fevers, yes. Systemically unwell, yes. That's the real point. So what happens is that the child has like certain condition, like the history would go that the child has eczema from certain age, and the child has been on treatment it was well controlled, but for the past few days the child is febrile, is like really toxic looking. The lesion's shape has changed. It's like the color has changed. So regarding the history points, if you get certain history of this, like if you get the history of fever and rash, you have to analyze that is the fever or rash a new thing, or is it an old rash which has now gotten worsened. So you will take all the detailed history of the fever, you will take all the details of the rash, how it was, how bad has it gone, like is it getting better, is it getting worse, it is red, is it weeping, all of those things, right? Is it like being affected? Along with that, you'll see that if the child is having any of the systemic signs of the toxicity about the renal or like any of the system that is being involved, right? So yes, eczema hepaticum patients can get toxic sick. So eczema hepaticum is basically widespread herpes simplex infection of the eczema. So this is a serious condition. You have to treat the child for IV with IV acyclovir, right? So you know acyclovir is your antiviral, which is for the herpes simplex majorly. This group, your like herpes zoster or herpes simplex groups. So you treat with the IV acyclovir for 5 days. So the dose is that from the age 3 months to 11 years, it's usually 1.5 gram per meter square per day in three divided doses. And for the age more than 12 years, it's 10 mg per kg 8 hourly. It's good if you can memorize these doses, but remember that this is not the hard and fast rule, or not a hard and fast criteria of passing the exam that you have to memorize each dose, because every time that you are going to prescribe, obviously you can go to the BNF and look at the doses. So if you can memorize, that's fine, but do not stress yourself a lot for this particular exam about the dosages, right? You just need to know that which treatment and for how many days that is recommended. That's more important rather than exactly the mg per kg doses. If the skin is healing well and there are no new lesions, consider changing to oral acyclovir or the valacyclovir after 2 to 3 days, and then you continue the treatment maybe for 10 to 14 days. Stop steroid creams or ointments until the no new lesions or the skin is healing. Yes, so on the active lesions, like so you see if there's an active infection going on, or there's a like weeping or everything on the skin, you're not going to apply any creams or ointments, the steroids on that specifically. You have to wait once that are healed, once the infection is over, then you are going to bring back your management of the steroids. Regarding the diet, usually you continue the normal diet unless the child has certain food allergies. If those allergies are documented, that so it gets worsened, or the child has some food allergies as well, then you can go for like omission of those components. Otherwise, you continue normal diet. If the child is less than 1 year and the eczema is really severe, in those cases, you will think of a possibility of caramel protein allergy, and you can go towards the hydrolyzed milk substitute for a 3 months trial. But remember that whenever you are going for the diet change, always refer to a pediatric dietitian, and do not like take all of this on your own, right? So in the cases, if you are seeing, like if in a video you are seeing a child who's maybe 7 8 months old and is eczematous, then you'll always bring the component of diet. In an older child, that might not be the case. Regarding the follow-up, all the children, they require follow-up in the outpatient appointment with the dermatology nurses, 2 to 3 weeks following the discharge. And obviously, you'll have a follow-up, like the medical team that has to complete the follow-up to keep the patient on the appointment. In the guidelines, if you have seen the eczema, there are two guidelines. One is the admission and the treatment guidelines that we have covered, the things that have written so far. And the second guidelines is about the eczema wet wrap dressing. So this is basically used for in the cases of very severe erythrodermic eczema, very widespread excoriation, and if the journal emollients and they are not being they're not treating the condition well, and the child is not getting better with that, then these wet wrap dressings are advised. So they're only to be prescribed after discussion with the pediatric dermatology nurse. They're useful for the severe erythrodermic eczema, widespread excoriation, and eczema which is not responding to the adequate therapy. If eczema is infected, then you do not use it. You do not use this on the face. If the concern regarding the infection, treat with the oral flucloxacillin. Never cover wet wrap dressing with a plastic, for example, a cling film, right? So basically, what you do in the cases of wet wrap therapy is that you bath the child, you bathe the child in warm water for like 8 to 10 minutes, and then you use a gentle cleanser. Then you lightly pat the child's skin dry with a towel. Then you apply steroids to the affected areas and the moisture to the non-affected areas, like within the next 10 minutes. Then you soak wraps in the warm water. So whatever the clothing is, like you kind of soak it. You rinse out the excess water and you wrap the area which are covered with the steroids and the moisturizers, emollients. You cover that with the wet dressing, like with the wet clothing, and then you like put a dry layer of clothing on the top, and then you remove the wet dressing after 2 to 3 hours and apply moisturizer to the entire body, right? So the main purpose of this is that you are basically, initially you are like bathing the child. So why are we again bathing the child? Because obviously when you bathe the child, you like with the warm water, so the skin does gets like softer as well, and it's like it absorbs the moisture and everything more, right? So after bathing you apply your treatments, and then you put a wet covering to keep that, like to improve to help the skin absorb all those moisturizing things, and then you wrap that with a dry clothing, and then after 2 to 3 hours you get that, right? So this is how you do the wet wrap dressing. If you see in the guidelines, there are a lot of points that were written. I did not write these here, but I quickly go through those. So basically, if the child is like they could, so what you can use for the wrap dressing are ready-made vests, leggings could be used, or there are certain like bandages that could be used as well. There are different bandages for the arms, lengths, body, vests, and you like use them according to like length and the height of the child. As I've already told you, you bathe the child, then you apply the emollients, and then you apply the steroids, and then you like put this wet dressing, and then you put dry over that, right? And then you change this wet wrap dressing twice daily, and always ensure that you're using the proper cotton clothing, and not like the kind of stuff the which is like irritating to the skin, right? So this is how you do that. So yes, you can tell about that in your management as well. Okay. Okay, so sharing this with you. So this is basically a quick go through of how you do like in the cases of eczema. So guidance for the journal, if you want, I will like share these few leaflets in the groups as well, in which you can see the different like the charts that you can go through. So in the mild cases of eczema, for acute flares, you apply a topical steroid, for example, hydrocortisone daily for at least 2 weeks. Consider maintenance treatment with twice weekly consecutive days applications. In the cases of moderate eczema, for acute flares, you apply a topical moderately potent steroid daily for at least 2 weeks, and then you go for like in cases. So you see, we have till now we have discussed the use of this nail care, emollients, steroids, and the wet trap dressings. If the things are not getting improved with all of this, then you can go like these could be stepped up for the calcineurin inhibitors, like for the tacrolimus in ointments. But the thing is that this is not for your scope. You should know what it's there, but you have to refer the child to a specialist for this, right? You cannot advise it on your own. So the child of moderate eczema is not getting better, so you'll obviously refer to a specialist, and then you will see that how it has to be gone through. And in the case of severe eczema, so basically mild, moderate, severe basically depends on the amount of the area involved, and obviously the amount of the dryness and the condition of the skin as well. So in the cases of the severe eczema, you'll use a topical potent steroid like mometasone, and then obviously you'll consider this calcineurin inhibitors and go for the maintenance treatments, right? So here's the list of the least potent to the most potent. So hydrocortisone is like the least potent. Then we have clobetasone. Then we have betamethasone, mometasone, and clobetasol. Right. So you need to have these. This is like they've told that how much it's the. So if you like have on your one fingertip, it's roughly zero point 0.4 to zero point 0.5 gram. This is basically how much do you have to basically use face, for the trunk, so how much you have. So you don't really have to go in the details of that. The most important thing is that you should know that which steroids are the least potent and which are the most potent, and how you will stepwise go through there, right? Along with that, always remember that whenever you are prescribing the steroids, obviously the parent would have certain concerns. So you have to tell the pros and the cons of the use for that, and you should be well prepared of about telling the parents if they have any concerns regarding the treatment, right? Okay. Yeah, so we have two communication stations next. I'm done with the discussing the guidelines. Do we have any questions here? Anyone wants to ask any question? Yeah, anyone?
Hello, ma'am. We don't use oral steroids in the treatment in eczema.
If ideally the our main thing, like main aim is to use like the topic
Okay. I was actually going through some communication scenarios where a role player mentions use of
agents,
oral
right?
steroids.
And like steroid for the topical, this calcium you can you can give short, you can go for the short term like giving it for like a short a typical practice in the guidelines, right?
Okay.
Re- Yes, you were saying something. Sorry, can you please repeat? Yeah, someone was asking a question.
Hello, ma'am. I have a question that according to the guidelines, I also went through the guidelines, but there is no mention of oral steroids, right? In the treatment of eczema.
Yeah, so
Hello.
there's no mentioning it there. Yes, in the guidelines, it's after the topical steroids. It's the topical calcineurin inhibitors, right? But there are certain in certain places, if you see that if the child is not improving, then you can give for a short course. But I would not recommend you to tell it in the management, right? So what you have to tell is that topical. If it's not the topical steroids, then you have to refer to the specialist, considering for the possibility of the calcineurin inhibitors. If there is the child is not improving, obviously you need to see that if it is infected or not, and then obviously you'll maybe go for the antibiotic therapy as well, right? But per se, in the typical guidelines, orals are not the basically recommended treatment in the NHS specifically.
Okay. Thank you for clarifying.
Any other questions? Okay, if not, then we'll go towards the communication practice. I think Dr. Sabha, you volunteered. Would you like to do the case? Yeah, was it you or who was there who volunteered for the communication? Anyone can volunteer. It's open and it's fine. Do not be upset. I think maybe Dr. Sabha, she left the chat. So who would like to participate? We have two communication stations. We want it to be an interactive one. So please come up. Even if you have just started the practice today and you have never ever logged in, all the information that I've told you right now, this is all that you need for the communication stations, right? This is all the
Dr. Iqra, can I do one, please?
Yes, sorry, who volunteered?
Me, Dr. Iqra.
Yeah. Okay. Anyone else? Yeah, Dr. Saish, obviously you are here. I wanted someone else to come up as well.
You have
Yes,
two,
please.
so anybody else will.
I understand, but still, I wanted the newer ones who are here to maybe. Okay, if anyone's not recommend coming up, I just want someone to tell me the reason that it's not like that. It's not that I'm going to mark you down or anything. Then what's the thing that's coming up? Okay, fine, Dr. Serish, this one's for you, but I want another person as well. So please, guys, message in the group whoever wants to do. Okay, Dr. Ellis, thank you so much. Yes, you can do the next one. Yeah, you ready?
Yes, Dr. Iqra.
Let me start the timer.
Yeah.
Okay, yes.
Hello, good evening. I'm Dr. Aziz. I'm one of the children's doctors today. I believe I'm speaking to Samira, mother to 4 years old Maria.
Hi, doctor. Yeah, that's me.
Thank you for coming in. How may I address you?
You can call me Samira, that's fine.
Thank you, Samira. Samira, I appreciate you have some concerns regarding Maria. I would like to discuss this further. Do you have any information what's been going on?
Yeah, doctor. I mean, my little child, she has been diagnosed with eczema, and like she's not getting better. I mean, the doctors obviously told me that it's just the skin dryness that you have to deal with, and you just need to apply some moisturizers, and obviously the emollients, they say that you have to use them. So I've been using them very regularly, but I don't know, her condition is not getting better. She keeps on itching at night, and she's really irritable. And obviously, you know that if the child does not sleep well at night, then she's really irritable in the morning as well. And obviously my gets everything gets upset. I have to go to work, and then I'm not
Mhm.
able to do that. So I just wanted to have like another option, any other treatment that could like make it better.
Yeah, I appreciate, Samira. This has been quite a troublesome time with you and Maria. And I'm sorry that you both have been struggling a lot with this problem. Samira, I understand that you have been offered some steroid creams. Is that right?
Yeah, yeah, doctor, I don't want steroids. I think just tell me any other
Okay.
thing. I don't want steroids.
Yeah. Uh, okay. Okay, Samira. Would you mind telling me what is bothering you with steroids?
I just won't want steroids, doctor. I just know that they're not good for my child. I don't want
Yeah.
to use steroids. Simple.
Yeah, I appreciate your concerns, and I think most of our families do have this concern with steroids. But I would like to explore it further, Samira, if you don't mind. Is there anything you're worried about side effect of steroids? Because it will help Maria a lot um, if something you are
Doctor, I like
maybe.
obviously I'm learned enough to like search about it, and I like read out on a lot of the information regarding the steroids, and it was written everywhere that like it causes a lot of side effects. It will make her thin skin really thin, and then it's going to like at times I've written like I read that it can cause the high blood sugar levels. It can cause a lot of weight gain. I don't want that, all of that for my child. I mean, there were a lot of side effects, so I would rather keep my child away from that. And obviously, I mean, the medical science is so big, so why can't you offer me another treatment?
Yeah, absolutely, Samira. I can see that you are a very keen mother, and you have got a lot of information on steroids, which is actually, in part, it's correct. But I would like to reassure you, Samira, that the strength we are using, it's a very safe and low dose, and the creams, if obviously used for a very long time, they can cause thinning of the skin, but we will use it for the shortest time possible, and the strength we are giving, the dosage which we are giving, it's very mild.
Doctor, tell me that why do you really have to just give? Um, I agree, but this every condition has a lot of different options of the management. Why cannot you give it any other medicine?
Yeah, thank you. Thank you for asking this question. So, Samira, as you know that eczema is a long, long-lasting condition. So, what we try to do is we will try to
You're
do a
gonna say
step.
that my child is not going to get better? He's always going to remain like
She will.
this?
No, she will get better, but there could be flare ups, which I mean that the condition will get better itself and it can sometimes come back. So if we work together, we can ensure that she keeps away from the flare ups. So what I'm trying to explain is, if we go in a stepwise manner, so we will avoid the more stronger things, and we'll not have to use other medications, and maybe this is for just very short time, and this will help us control.
So
What do
you
you
tell
think?
me that, so you're saying that there will be no side effects if I just use it for a short period of time.
Samira, Yes. I can say certainly yes. If we would avoid a lot of side effects because we will do it for a very short while. But if this is something you want to explore further with my consultant, I'm also very happy to arrange another meeting. But yes, if it is something we offer.
Fine. I mean, obviously, I will talk to the seniors as well, but obviously, you are here to talk to me. So, what other options can you suggest me? And I'm honestly, I'm not really convinced with your statements that why is it really important for my child?
Yeah. Okay, Samira. So I know that you are working very hard with Mari and you're doing all the things which we have told you, like the emollients and
3 minutes
moisturizers.
left.
But sometimes we do need steroids when we think the skin has a flare up. It is used for a very short while, and I think this will be best for a very short period of time, and then we can come back again to what you are doing already. What do you think about it?
What if it does not get better with the steroids? Then what? If your treatment
Yeah.
plan
Yeah.
fails, then
Absolutely, yeah, you are right. It may that we have to use some other bigger potency steroids, but if we are doing the basics right, then I'm hopeful that this is something we can control.
but what if not?
Yes, and then we'll have to step up the treatment, and that will be going on higher potency steroids.
See, I knew that this is not going to work. I really think I need to get in consultant. So doctor, I was studying and I also got to know that maybe you can change a few medicines as sorry, some things in the diet to get the eczema better as well. So do you think that I should change her diet?
So, if you have clearly noticed a pattern which you feel that it makes various eczema worse, then yes, this is something which we will encourage you to do so. Are you with me,
Okay,
Samira?
and what specifically should I be like on my own doing all of? Yeah, but do you think I should be doing it all on my own?
Samira, so if you clearly notice a pattern, we can get you in touch with the dietitians and they will be very happy to offer you more support. Is that okay with you?
Fine, doctor. I don't know. I'm still in a doubt, and I'm not really sure that this has all been like this discussion has been very helpful for my child. I really think I need to discuss this further with some senior person to like maybe see because my child is in real trouble, and I really want all of this to go.
Yeah, I can see that this is very upsetting for you, but I want to reassure you that steroids is beneficial and it will not have the side effects like what you mentioned with high blood pressure and high sugar levels. But if you want to meet the consultant, I will arrange a meeting with my consultant. That's not a problem.
Yeah, that's fine,
Is
doctor. I
that
think
okay?
that you should do that. Yeah.
Okay, thank you. Any other concerns or anything I can answer today?
Yeah. Will my other kids have this condition as well?
So, Samira, if you have a family history, then the chances are high. But having eczema in family does not mean necessarily that your other children will have the same condition.
Okay. And can I do
Okay.
anything to prevent in my kids?
So, there's not a lot of evidence we can do to prevent
The time is
eczema.
up. Time's up.
Thank you. Thank you.
Yeah, sorry, I was not planning to go for this, but when you asked me at last of the scenario that if I have any other concerns, so
I
for just
can't
for the practice
resist.
purpose,
That's fine.
yeah, so for just for the practice purpose, I plan to come up with that. Just like make sure and tell other people that this is something that we should not do in our communication stations. Yeah, so good attempt, Dr. Sarish. But yeah, a little off from your typical cases, but we'll discuss it. Um, Obviously, the information, everything is right. A few of the things I felt were a bit unaddressed. Yes, the initial was very right, and okay, so basically, this is not something for all the candidates. This is not something that I'm typically telling it, and basically, I'm not going to like pinpoint what Dr. Sarish said. I'm going to have a journal discussion about how and what things should we do in any of the cases or any of such scenarios where you are proposing a treatment to a mother and the mother is saying no to that. So the thing is that whenever the mother says no to any treatment, there's always a reason, and you have to find that particular reason. You have to find out why the mother is saying no, and then you have to deal with it, right? And you have to have the confidence of saying that the side effects, what I wanted Dr. Serish want to say, that these side effects are usually more commonly occurring when steroids are taken per oral or from the mouth. With the topical application, there's not a lot of, and specifically if we are starting with a very low potency, so there's not a lot of steroid that is going into the blood or into the body to cause all these side effects. So with the mild steroidency, and when what we are doing for at this level, we assure you that there are not going to be a lot of side effects. Other than that, whenever see this, what you why when I was telling you that give me another medicine option, or if the parent says in any of the other condition that give another option, you have to tell that whatever medication you are going to give, there is going to be some benefit and some side effects of that medicine, right? There's no medicine which has like no side effects. So what is our aim is to have a balance and to see that the treatment that you are using, what is the risk versus benefit ratio. If obviously the benefit is more, because in this trial you had to emphasize that we have to see that is the medicine giving more benefit to your child or is it at giving more risk. So in your child, Maria is having itching at night, she's being restless. So what's going to happen is that if she's not getting enough sleep, she's going not going to be able to grow well. There could be a reason that she her overall health and development might get affected or hampered, because obviously she's not getting proper sleep, she's not being rested, and overall her health condition is not going as it should be, right? So you have to emphasize that she's in trouble, she needs to be taken out of that trouble. And yes, I agree that there could be, but the possibility of those is very less, and the benefit that this medicine is going to give her are a lot, right? So you have to ensure the method, then she's going to agree to that, right? And secondly, you have to tell that whatever medicine you will give, that is going to come up with some side effects, right? So obviously you have to take in mind of that. And along with that, I think yeah, understanding was checked once, it could be have been checked once before as well. And for all of those, usually what we recommend is that, you see, every one of you, if obviously you know that we have a 9 minute station, there's a 6 minute, at 6 minutes I told that 3 minutes left. Once the 3 minutes bell is gone, then you try wrapping up the things, and do not ask that is there any other concern at the very end, like at the last 30 seconds. At this point, the right approach should have been to just summarize rather than asking, because if you ask a concern and that has not been like this scenario right here, it just ended in between, that is going to cause more of an issue rather than not asking that, right? So try that, do not ask any new questions at the last 30 seconds, and wrap up what you have already discussed to just give a proper closure to your communication station, right? Yeah, anything anyone wants to say?
Dr. Ikra, did I answer correctly for the dietitian thing?
Um, yeah, that was okay. Yeah, but you should have told by yourself that if you have concerns that certain foods, um, like get that. So obviously, you see, the mother would not stop it on her own. Like that's why I asked that should I do it on my own? So the right response should have been that if you feel that her skin gets or her condition gets worsened with certain foods, then I can get you in touch with a dietitian and you can discuss with that, and then we can plan maybe modify a modified diet plan for her. Okay, people
Just one
messaged in
last
the
question. What
Iqra,
is there anything that could have been said differently to convince mother of what I can add?
yeah, what I told you, that you did not convince me that why giving steroids is so important. I was not convinced. I was convinced that it might not cause, but even I was not convinced that it might not cause. You have to tell that the side effects that she is talking about is more with the oral. Then obviously there's a risk benefit ratio. The benefits are more for her child, right? Risks are not that high. And the third thing is that if you are asking for another medicine, then that medicine is going to have some side effects as well, right? So obviously you have to choose what is best. And obviously this is the decision that we have made as a team of doctors. And obviously we want to do what is the best for child. So for her best interest and for her normal growth, for her development, for her like improvement of the whole condition, the steroids are important at this point.
But Dr. Ikra, then the role player continued that what if it doesn't help? So you said that
Yeah,
it
so
would
you
mean
see that I understand that you are very apprehensive, but the thing is that right now we just want to start the treatment, even if there's a possibility. So why I what I want to ask is that then you're going to refer it to a specialist, to a dermatologist, because the thing is, if not getting better, then obviously then you're going to involve a specialist. Then mother can say then involve a specialist right now. That could have been a counter argument as well. But you see that if a nephrotic is not getting better, then you refer. If this is not getting better with the steroids, then obviously for the higher potency steroids and for the like tacrolimus or all of these things, then you have to refer to a consultant specialist.
okay, okay, Dr. Ikra, thank you.
Dr. Ikra, what is the chance for the second baby to be affected? Like the second,
That
the
was just
mother's
a random
concern.
question. That was
There
just a
is no
random question.
association. Yeah,
No,
yeah,
if
yeah.
there's a family history of atopy and there's
Mm-hmm.
something
Mm-hmm.
there, then yes, there could be a chances. But
Yeah, yeah, okay.
but I'm afraid that obviously we cannot do anything to basically prevent that. But obviously we can,
Yeah.
if the child has that, and obviously we can manage that. But obviously you can't really prevent that from coming. But yeah, there could be obviously increased chances if there's a family history. Obviously, there's a family history, like one child has it, so obviously there would be some atoping going on. So there could be chance that other child has something like that as well. Okay. Any other question or Dr. Alice, you ready to do the next station?
Oh, yes, ma'am.
Okay. This is your station. You have 4 minutes to prepare. Ready?
Okay, ma'am.
Just a second, let me start the timer. Yes.
Hello, I'm Dr. Alice. I'm one of the children's doctors in this hospital. I believe I'm talking to Miss Jenny, mother of 8 years old Sam.
Yes, that's me, doctor.
Hello, thank you so much for coming here. So how may I address you, Mrs. Jenny? Should I call you Jenny or Mom is fine?
Yeah, Jenny would be okay, thank you.
Okay, Miss Jenny, do you have any idea why we are here today?
Um, yeah, doctor. Doctors here at your clinic told me that they are going to de-escalate our treatment and they are not going to keep us on the follow-up for Sam here. And I'm really upset about that.
Oh, I'm so sorry to hear about that. Miss Jenny, before we start our discussion, would you like anybody else to join our conversation with us?
Just I'm pausing it for a while. Dr. Ellis, are you like speaking with the hands, the mics on, or the you have?
Put it on the normal.
Okay, I don't know. There's a lot of echoing. Maybe you can come it closer or something. There's a lot of like it feels like the voice is very coming from very far, and I'm unable to like focus on that.
Is it better now, ma'am?
Yeah, it's perfect now.
Okay, Miss Jenny, would you like anybody else to join this conversation?
No, that's only me. It would be only me. Thank you.
First of all, Miss Jenny, I would like to appreciate that you have taken such a great care of Sam, and his eczema, his flares have settled, and now Sam is doing so well. So,
Yeah, you
so I
don't know
really
doctor, how much have I put effort in treating him. It's been so many years of hard work, and obviously he had to go through so many things. I mean, we had to go through all of these ointments and then the wet dressings, and you know that multiple times there have been infections as well. So it's been quite a harsh time, and obviously the last year had been quite bad as well. I'm very helpful. I'm very grateful to all of your team that you helped me in all of this, and he's doing really better now. But I'm really upset that why all of a sudden you feel like that you want to just throw me and Sam away from your clinic. I mean, why would you do that?
I'm so sorry that you feel this way, Miss Jenny. But now that Sam is doing really well and his flares have settled, and you have shown great confidence in dealing with his flares, and you have a lot of information, and we feel that you are very confident in taking care of Sam and his flare ups. And so we have decided that it's better that we put Sam on
How
GP
is it
follow.
better, doctor? How? Tell me that how is it better? I mean, he has been on the care of this, like your consultant for such a long time. You all of you know all the history, you know that how he went through everything. So you know about him. How do you expect that if you go to a GP who has not seen him before would be a better option for Sam? I really don't understand that. How do you come to this conclusion?
Okay. I'm so sorry that you feel this way. And but it's not like we are totally cutting our connection here. We will be um, our GP follow will be it will be a closed what I mean to say it, we will be in touch, but we will be in touch with the GP. And if in any case, if any flare-ups happen, and if the GP follow-up is not able
So
to,
you see that you have to be in contact with the follow up, obviously with the GP as well. And then if a flare comes, then I have to again come to you. Then what's the point of sending me to the GP?
Jenny, I know that you are upset, but now Sam is doing really well, and so now we believe that Sam does not need consultant follow-up, and
But doctor, I'm not satisfied with you sending me to the GP. I mean, I am his mother and I know what's best for my child. I mean, is it because You think that we cannot afford all of this, and you think that you have better people who can pay you better. That's why you are doing that.
No, no, Miss Jenny, it's not like that. Please don't take it the wrong way. We are always here for you.
Hello.
And it's just that now the Sam's eczema is so much under control that we are just
Yeah, I'm
scaling down
telling
our
that it is
follow-up.
under control. I understand that, and obviously, all of the things that you're saying is right. But I'm telling you that if you have to be in contact with a GP and you're going to tell all the things to him, then why not? Why not that we come here directly? That's for my own satisfaction.
Miss Jenny, I totally understand your frustration. I'm so sorry, but you will have to wait. Um,
Fine, keep going. It's
but
okay.
it's better that if we scale down a follow-up so that you have less waiting time for appointments. And if there is any need, our GP is going to contact us anyway. We will be in touch through our letters, and we will be constantly marking your
So,
progress or marking Sam's progress.
so you won't consider my concern. You see, he's my only son, doctor. Sam is my only son, and you know that I don't even have my partner with me. I have to take care of Sam. And you know, when he gets sick and when he gets all of this condition, it's really hard for me and gives me so much anxiety. And I'm telling you again, 3 minutes left, and I'm telling you again and again that if you do that, that I will not be comfortable, and still you're not considering it. I mean, isn't the parents' value comments and their suggestions valuable?
Ma'am, I'm so sorry that I'll have to cut this communication station so short because I'm on duty and I've been getting
Oh, okay.
constant calls from the parent. I'm
It's
so
fine.
sorry for that.
Thank you. Thank you. No, no. Thank you so much for participating. Okay. Okay. So, okay, we'll quickly just go through that. Yeah, so anyone can tell me, Dr. Sarish, what are the main points that why do we defer or de-escalate?
As Dr. Ali said that it's now well controlled and flare-ups are not happening that much frequently, so we can de-escalate the care. For what I will add that to ensure the continuity of care, we will pass on all the information to our GP colleagues, and our GP colleagues are very competent enough to deal the situation. What mother was saying that you know the history and why would you not keep it there? So obviously we will pass on the information, and we can also add that coming to hospital, although you feel that it is something you want to continue in the future, but it coming to hospital all the way is not very psychologically for Sam. He's 8 years old, so he understands. So sometimes children do feel overwhelmed, and it's distressing for them. So closer to home, GPs surgeries are very close to home, and it will be just one of appointment which you can go like very quickly, and it will not be very upsetting or distressing for Sam, and he will also be very happy seeing that his eczema is controlled and he not have to go hospital and again. And also you will feel confident once you see that it is settling down and GP is managing it well. And Dr. Ellis rightly said that we are not closing the doors. If something happens in the future and the GP colleague or you feel that it's not working well, so you're very welcome, you can come back. Like de-escalating doesn't mean that we will not see you again. Basically, I think
Yeah,
this
yeah,
is what
that's
our
basically
message is.
yes. Yes, thank you, Dr. Seri. Yes, so first thing is obviously the important point is that unnecessary hospital visits, they can be time consuming, they can be stressful to the patients. So the keeping like de-escalating to the GP, where you can get the appointments easily on the need basis. So it will avoid the unaided trips. Then the GPs there, they are not that you're sending them to a very new GP. The GP has been always been the main primary caretaker of the child, and he has all the history as well, and obviously you're going to send all of your records to him as well, so they are, as you said, they're competent enough. Then another point that you can add is that you know that the specialist resources, because the optimal use of specialist resources, because when we like refer the stable patients to the GPs, then obviously the other patients who have the more complex and the acute or the unstable conditions, they can get the help from the specialist as well, right? And obviously about the empowering of the patients and the parents themselves, that they can manage in the conditions, and for the overall system improvement as well. Regarding the concerns, the mother was very upset and all of the things that she mentioned. So you need to like have a little bit of empathy that all of you are going through all of this. But we as a system, we are here for you, and we are here to like support you in any way possible. So yeah, all of this would be like it. So both of these communication, these are from the recalls, and they have come multiple times in the past. um so Dr. Adam, you raised your hand. Do you want to ask any question?
I wanted to add that we should reassure the woman, just like you said, that she's in the right place, and that if she needs to go to if we will decide, since the flares have reduced, number one, then we can also tell her that it will cut down our infection rate, because going to a tertiary institution where the consultants are the dermatologists is will mean more people being in a place that is not necessary. Are we there?
Yeah.
Hello?
Yeah, thank you. Yes,
So
yes.
it will help. So it's important to tell the woman at this point, or the mother at this point, that taking the child to meet the consultant at the dermatologist will mean child will be mixing with children with different ailments and infection. So to cut that down is best the GP. And moreover, in the GP, there's a lot of emolents available for a son to use. I don't know whether it's important to add that.
Yeah, so your points are right regarding the infection and all of those things, that you might not have to mention that, because obviously even if you're coming to the hospital and everything, so it's being like properly managed, that you're not getting in like in touch with the infection and all of that. But yes, let the GP, that it would be easier, and it would give more confidence to the parents as well, right? And obviously it is going to be better for both the parents and for the child himself as well to be on there. And obviously that it's not the end of the story. You are going to be in touch, and if at any point any escalation is needed, then the GP is going to do that as well, right? So we are all like, we'll be always be available if he needs us.
Yes, thank you so much.
Thank you, Dr. Adam. Okay, so thank you so much, everyone. I think this is all that we have planned for today. I hope this session was helpful for those who joined. I would want you to like give me any comments in the comment section. And if you think that we need to have any of the further webinars, then I would like to do that as well. Before closing, I would just like to give you a heads up regarding our coming course. Let me just share my screen in a second. Yes. So we're starting our batch 6 of the clinical course. If you guys are in a group, you know that just yesterday the result for the UK center came, and we have an amazing results. Lots of our candidates passed from the UK center, which is one of the most considered to be the difficult centers. So we did really well. Our team who has been with us, if you know that this is our team at MRCPCH clinical courses, we have gone through 5 courses, 5 badges. Dr. Madiha, Dr. Nadeem Iqbal, and me, Dr. Iqra. This is going to be like, initially we had different mentors, and we three have completed our 2 courses, and our next batch is starting from the 15th December 2025, and we have starting registration for that. So what you get in our course, if you already don't know, and you want to share it with your friends as well, you have more than 50 plus live detailed sessions, We have the mock sessions. If you want to have a feedback from our recent participants and recent candidates, we arranged a 2-month long daily mock courses for our exam in which we covered all the past recalls. Then all our classes are practice based. We have a proper schedule that is being given. You get all the recordings and the PDFs. We take all the feedbacks and we keep on improving and changing according to what they need. Then every station is covered: history, clinical, communication, development, all of these. And then we have WhatsApp group as well. And all of our mentors, we are easily approachable as well. So if you want any of the personal guidance regarding any of the things, we are there to help you as well, right? So if you plan to give your exam in the coming times, then please feel free to please feel free to contact us and join our course. If you want, then maybe we can give you a one mock class as well to let you know if you want to like join the course or not. Dr. Jaya, you're saying if possible, can you please arrange feedback meetings of successful candidates? I'm sorry, Dr. Jaya, actually, we don't do the public feedbacks. I understand that you guys want that, but there's a lot of hesitance from the candidates as well, because kind of it's like obviously it's exam is they're always, whenever you go and give the exams, the examiners are very particular that you do not have to mention any of these things to anyone. So a lot of people are there, but the thing is that we do take feedbacks from them, and whatever content that we have in our courses, all of that comes from the discussion with the people who are giving the exam. So yes, we get the feedback from them regarding the questions, regarding the sessions, and then we put all of that in there. If you have any specific questions, Dr. Jaya, if you think that you have confusion in any specific thing, or you are like afraid of any specific station, maybe you can message us and maybe we can get you connected with someone who can help you in that, right? Thank you, Dr. Faisal, for joining in. I hope it was helpful. Dr. Shawal, Dr. Tasneem, Dr. Diana, Dr. Jaya again, Dr. FS, yeah, all of those who joined in and giving your time. It's not easy to just join in and like get in touch. So thank you so much. And if you have any feedback that we should do webinar on any of the other topics, then feel free to share that as well. Yeah, Dr. Zaid, you are saying that what is the duration of full course? Okay, so the full course is roughly um you can say it's around around 4 months, 4 to 5 months. But the thing is that it's not that if you have attended the course, then you are just like sent out of the group. If you are in our group, still the time you give your exam, you are going to be included in all our upcoming courses as well, right? So right now we have a lot of participants who were a part of our previous course, but obviously they have not given the exam yet, so they can join our further classes at any point of time. So at times what happens is that the courses, like if the present course candidates, they're not actively participating right now because they don't know, then they can come and then like they can participate in the next courses as well, right? Dr. Serish, you raised your hand, you want to say something?
Dr. Iqra, if the team is planning for more webinars like this, I would really appreciate if we can do a video of differentiation between infected eczema, eczema herpeticum, infected chickenpox. I struggle in a video station to differentiate because they look similar, although they are not similar. But I think when you will be in exam, it has to be very clear which thing is which. I'll really appreciate
Okay.
if we can do this for the next time,
Okay.
please.
Okay. Okay, we'll take that up, and obviously we'll get some good pictures in help with certain dermatologists as well. And we'll see to maybe arrange something about that in the coming future. Thank you for your suggestion. So our groups are open for all of you. You can obviously message in the groups as well regarding your suggestions. And if you have any of the you need any information, you can message on the groups. The contact number is mentioned and get the details. And if you want like a mock class to be attended, just for one practice session, we can offer you that as well, right? So thank you so much, everyone. Yeah, thank you, Dr. Asma. Looking forward to see you in
Thank
our
you very much.
courses. See you maybe in the next webinar. And to all my dear candidates, Dr. Batuhan, Dr. Adam, Dr. Serish, see you in next 2 days in our
Okay.
next session. Thank you so much. Have a very good night, everyone. Bye bye.